Good afternoon. I am Dr. Barbara Malkus, Board President of the Massachusetts Breast Cancer Coalition, and I am very pleased to welcome all of you to the third annual Margo Simon Golden Memorial Webinar, an update on metastatic breast cancer. I am honored to be here today to serve as the moderator. Before we begin today's program, I would like to share MBCC's mission statement. Massachusetts Breast Cancer Coalition is dedicated to preventing the environmental causes of breast cancer through community education, research advocacy, and changes to public policy. I would also like to take this opportunity to tell you about the person for whom this annual event has been named. Audience are likely already familiar with Margo, who sadly passed away in 2021. Margo served in the same role that I am in as board president for over a decade. She was a tireless advocate for and believer in the Massachusetts Breast Cancer Coalition's mission of preventing the environmental causes of breast cancer. More so, she was a compassionate ally and friend to so many in the MBCC community. She is missed by all who knew her, personally and professionally. We are honored to have Margo's family with us today as we honor her legacy with a discussion on the topic so important to her, followed by the presentation of an award in her name. Before we begin, I would like to hold a moment of silence and remember Margo. Thank you. Now I would like to introduce our panelists for today's webinar, Dr. Michael Misialek and Dr. Seth Wander. Dr. Misialek currently serves as Associate Chair of Pathology at Newton-Wellesley Hospital, Newton, Mass. He is the Medical Director of the Vernon Cancer Center Chemistry Laboratory and Point of Care Testing. He practices in all areas of pathology in a busy community hospital. Holding an academic appointment at Tufts University School of Medicine, he regularly instructs medical students and pathology residents. Dr. Misialek also serves as MBCC's medical advisor. Dr. Misialek, welcome.
The honor.
I'm sorry to interrupt. Go ahead.
Sorry. Yeah, thank you very much for the kind introduction and the honor to present today. I'd also like to introduce my co-presenter, Dr. Seth Wander. He's a medical oncologist at Mass General Hospital with a clinical and translational research interest in breast cancer and cancer genomics. Dr. Wander is active in both the clinic and laboratory, where his research interests involve genomic mechanisms of resistance to targeted therapies in metastatic breast cancer. His research is focused on leveraging genetic and molecular sequencing results to understand how cancers become resistant to standard therapies in order to develop novel, personalized treatment strategies. Dr. Wander, welcome.
Thanks very much. It's a pleasure to be with everybody today.
Thank you to you both.
Great, thanks. I think we're going to have a nice presentation here. I'm going to tee it up by presenting how the pathologist participates in care of breast cancer patients, and in particular metastatic breast cancer, and how we go about working patients up initially that gets them into the process here for therapy and working hand in hand with our clinical colleagues such as Dr. Wander. You should be able to see the first slide here. I have no disclosures. I wanted to start off quickly just by a quick definition of what is metastatic breast cancer. And metastasis is defined as tumor spread beyond the primary location, whether it be distant regional nodes or an organ, bone, brain, liver, lungs. These are all sites that breast cancer can spread to. There's two scenarios of which we encounter metastatic breast cancer patients here and on the pathology side, and that's a patient who has a remote history of breast cancer and now is presenting with a suspicious lesion elsewhere, for instance, a lung nodule or a fusion, a bone pain where a bone scan has found something unusual and that needs to be sampled. The other rare scenario of metastatic breast cancer is a patient who presents with a metastasis as their first sign of what turns out to be breast cancer. And this is a minority of cases, but it does happen. So first of all, how does breast cancer spread? It usually spreads by lymphovascular process, meaning it spreads through the vessels of the lymphatic system or even blood vessels that feed and drain the breast. As you can see in this diagram here, the primary tumor, labeled 1 here, can sometimes shed cells into the bloodstream or the lymphatic system, of which they then can circulate throughout different areas of the body. Often the first stop in a tumor cell that escapes is a regional lymph node in the axilla, and it's not uncommon during breast surgery to sample those nodes to make sure that they are free of disease, or if they are, to do a more regional resection of additional lymph nodes to try and get all of the spread. Those cells may deposit in lymph nodes or distant organs and undergo development of proliferation and a small tumor, and at which point it would be clinically detectable as a metastasis. And how do we go about sampling those metastases? Here at the hospital, we've set up a service that we will take our microscope to any area of the hospital, and it's generally interventional radiology. Sometimes it's even to offices or into the OR. And we have a cart here you can see set up. Here's my microscope, there's some stains, and we will go to an area of the hospital. Here's a shot of us in one of the interventional radiology suites, me looking at a specimen that is being sampled at that time. And the reason we go there is to make sure that the lesion is appropriately sampled. We have enough of tissue present to make a diagnosis, not necessarily to make a diagnosis right at that time, but to ensure that the radiologist or the surgeon who's sampling the lesion has enough tissue that we're able to work it up and not have the patient come back for an additional procedure. The types of tissue that usually come out when we're sampling a suspected metastasis, such as a lymph node or an organ, look like little threads of tissue, and that's because the biopsy is usually done through a small gauge needle, and it pulls out cores of tissue very similar to stereotactic breast biopsy when we initially diagnosed breast cancer. Those little fragments of tissue are put into cassettes in the lab, which then get processed through a multi-step overnight series of sequences in an instrument that dehydrates the tissue and eventually gets embedded into paraffin. As we see here, this is those strips of tissue. They're embedded in paraffin, which then allows us to cut it on a microtome into small slivers of tissue that are held together in this paraffin wax, which are then placed onto a glass slide, stained, and I read them under the microscope. The most important thing when we have a suspected metastatic breast cancer is to look at ER, PR, and HER2 expression. That's going to impact directly on therapy, and Dr. Wander, I know, is going to talk a lot about that. So as a routine, whenever we have a suspected tumor that could be a map from a remote history of a breast cancer, we're going to do estrogen, progesterone, and HER2 receptors. We're going to repeat them. And here's a slide of just what that stain looks like. The brown dots here are nuclei of tumor cells that are expressing estrogen receptor positivity. And estrogen receptor is a nuclear protein, and the stain thus will highlight nuclei of tumor cells that do express estrogen. The same holds true for progesterone, not as important as PR, but nonetheless, it does aid in prognostication of patients. And here we see a tumor that is strongly PR positive. The final stain we do on these types of tissues is HER2. And HER2 is a transmembrane protein that takes signals from outside the cell and turns them into signals inside the cell that tells the cell to drive proliferation, migration, and ultimately tumor growth, invasion, and survival. That's why HER2 is an important biomarker to assess for in breast cancer, because we want to turn off this switch if it is overexpressed, as one way to halt the tumor from further growth is to stop this signaling cascade. And we have a number of different agents that are targeted against HER2 that we can use in that scenario. And here's what the stain looks like for HER2. It's a little bit different than ER and PR in that it's not a nuclear stain, but it's a tumor that expresses HER2 or overexpresses it. You're going to see it stain very darkly and in this membranous pattern of staining where it highlights the nucleus. So it's the reverse staining of estrogen or progesterone in that we're staining the cell membranes. Now I want to switch and see if I can accomplish this to what it actually looks like. And you should be seeing an image of a core of tissue. This is an actual biopsy, and it's a lymph node. It's not a normal lymph node, but it does show replacement of the normal architecture by these clusters of cells. And this is turns out to be a lymph node that is completely replaced by tumor. Instead of lymphocytes, which are the normal component of a lymph node, we have clusters of tumor cells. These are cohesive clusters of epithelial cells that, if we go into a little higher power view here, this is all tumor. And this is one scenario that the pathologist may be faced with is, for instance, this was a axillary lymph node, and we know the patient had a history of breast cancer. So high on my list would be proving that this is breast cancer and not a metastasis from another primary, perhaps a lung cancer or something else. And the way we go about that is doing different stains that have antibodies linked to them that I can identify sites of origin for these particular cells. And this type of stain here that I'm showing you is the routine stain that we use every day in the pathology lab. It's called hematoxylin and eosin, and it stains various shades of purple and pink to highlight nuclei, proteins, cells, and the cytoplasm. And this just simply tells me that it's a metastatic tumor. Now, one antibody that I can use here, and you'll see this is a bit of a different stain. It stains the nuclei very much like that estrogen receptor stain that I showed you, but this one is called GATA3, and it's an antibody that we use frequently to determine breast origin. It's fairly specific for breast, but it does have positivity in other tumors, which is why we often do a panel of stains, multiple stains. No one stain is going to prove site of origin per se, but it's a combination of multiple stains put together with the clinical history, working with our colleagues to determine the site of origin of an unknown tumor. So here we know that the tumor expresses GATA3. And one other stain I did here is estrogen receptor. And you can see this one is strongly positive. So we know in a patient with breast cancer who's got a metastasis in a lymph node remotely from her history of breast cancer treatment, that this is now recurrence or metastatic breast cancer in the lymph node. Now, another scenario that we sometimes see is not just tissue sampling, but we can also sample fluids. For instance, a cancer patient may come back with fluid in their abdomen. We call that ascites. They could have fluid surrounding the lungs, a pleural effusion, and sometimes those effusions can be malignant. They can contain malignant cells, and that would be another way of proving a metastasis. This particular patient, this is a different patient now. This is a patient who had breast cancer in the past and now presents with a bilateral pleural effusion. And I'll just show you, this is now a different preparation because we're looking at cells within a fluid rather than a piece of tissue. And I'm just gonna focus in on a group of cells here and just tell you that these are a cluster of malignant cells. I know that because there's variability in the size and shapes of these. You can even see a little nucleolus, that's the dot inside of the nucleus. But just like we can with tissue, we can stain fluid samples. And if I then show you that same GATA, well, first of all, let me show you the cell block. We will take that fluid and we'll spin it down and make a preparation that gets embedded into paraffin, just like we did for tissue. And these are malignant tumor clusters. Some of them are single, some of them are 4 to 6 size clusters, and some of them are multiple numerous cell clusters. And you can see a lot of changes in the cells. They look very different from cell to cell. Some of them even have these big mucin inclusions. And this is fairly diagnostic for a metastatic adenocarcinoma, but just as we have with a tissue biopsy of a tumor of unknown origin, we can also work this one up. And this is that same GATA3 stain that I showed you on the tissue, but now this one is really highlighting nicely all of the tumor cells that we saw histologically on the last stain. And even more so, we can appreciate that there's a lot of tumor cells that we didn't appreciate so much in the H&E stain. There's a lot of single cells. And this one, again, we would do ER, PR, HER2. Here's the corresponding ER stain, that's the estrogen receptor stain. And this one is strongly positive. It turned out to be progesterone positive as well, and the HER2 was negative in that case. And that's the way that pathologists will be called in to help with the care of metastatic breast cancer patients, and that will establish the diagnosis, will provide the oncologist with appropriate biomarkers that they will then use in developing a treatment plan. There are a couple of other things that I'll just briefly touch on that I know Dr. Wander will probably mention in his talk. We can also provide a little bit more information. The patient may also, if they haven't already been tested for, they may be tested for BRCA gene mutations, the BRCA1 or 2, so-called breast cancer gene mutation. And the importance of knowing that status is that we have a category of drugs here called PARP inhibitors that will, in the normal situation, a cell will frequently encounter abnormalities in the DNA when they're trying to divide and grow. And we have normal spell checkers in our cells that will repair that DNA breakage called PARPs. And if we inhibit a PARP, then that DNA damage can continue to a full break of the whole chain of DNA, at which point a tumor cell that is BRCA deficient can't repair itself and would lead to cell death. Whereas benign cells that have an intact BRCA gene can repair that mutation, and that's a way of targeting breast cancer cells for therapy that may be BRCA positive. There's a couple of other things that we may assess in the pathology lab that will be helpful for the oncologist. Some breast cancers, particularly those that are what we call triple negative, meaning they're estrogen, progesterone, and HER2 negative, they may benefit from immunotherapy. And what immunotherapy briefly involves is harnessing the body's own immune system, the T cells, to attack tumor cells. And one way that tumor cells evade the power of the immune system is that they can somewhat cloak themselves using a PD-L1 receptor and the analogous PD-1 on a tumor cell. And if this binds, a T cell will recognize the tumor cell and get fooled that this is a host cell, it's normal, we shouldn't destroy it. But if we present a drug that is an anti-PD-L1, it can block that binding, and then the body can now recognize that this is indeed a tumor cell, and the immune system can be called in to help with destroying the tumor cells. Here's an example of what the PD-L1 stain looks like. Here's a tumor that is PD-L1 negative, and there's no brown staining at all. Remember when I showed the estrogen progesterone stains that we would see some positivity often, but here's a completely negative PD-L1 stain. Here's one that's PD-L1 positive. It's a membranous stain, so we see it outlining tumor cells, and that's helpful information in that we can provide to the oncologist. The final slide here that I want to talk about is just briefly introduce a concept here, and I know Dr. Wander is going to talk about this some as well, but utilizing sequencing of the tumor DNA to look for weaknesses, to look for the Achilles heel in that particular tumor that may be matched with a specific chemotherapy agent that is targeted therapy against that tumor's particular mutation. And we can collect tumor in multiple ways. We can use those paraffin blocks that I showed you that could be tumor from a metastasis. Here we see a lung metastasis. We can also sample tumor from an effusion, and I showed you how we do that on a pleural effusion. We can also use that fluid, or we can collect it from blood, and we can spin down the blood, collect the plasma, and look for circulating DNA or tumor cells within the sample and extract that and then analyze it and look for different mutations that may give us insight into the choice of appropriate chemotherapy for that patient. And that's how pathology will work hand in hand with our clinical colleagues, our oncologists, to help them in designing an appropriate plan of therapy for the metastatic breast cancer patient. And at this time, I'd like to turn it over to my colleague, Dr. Wander. He can continue with his portion of the presentation. Thank you.
Thank you, Dr. Misialek. That was great. I'm just trying to get my screen shared. Great. Well, as I said, it's a pleasure to be with everybody today. Thanks so much for the invitation. I'm going to build upon everything we just heard about and focus a little bit on our clinical approach and some emerging technological advances for the treatment of metastatic breast cancer. Here are my disclosures. And I think you guys are seeing the wrong side here. Hopefully that's better. Okay, so here are my disclosures. And these are the topics we'll cover over the next few minutes. I'll talk about general principles and therapeutic agents that we're using for metastatic breast cancer. I'll focus a little bit on CDK4/6 inhibitors and mechanisms of resistance. And I'll talk a little bit about ESR1 mutations and how we're developing new anti-estrogen blockers, and then we'll end with talking about future directions. Because we only have a limited amount of time, and because this is a very large, rapidly evolving topic, I'll focus today on hormone receptor positive or estrogen receptor positive metastatic breast cancer, which we'll see encompasses about 70% of all breast cancer is estrogen receptor positive. So breast cancer is the most common type of malignancy diagnosed in women in the United States. You can see statistics from a few years ago here below from the American Cancer Society. And you'll also notice that it's not even close, right? There's more than double the amount of new breast cancer diagnosis than the second most common cancer, which is lung cancer. At the same time, breast cancer is not the most common cause of cancer-related death. That's lung cancer. So even though breast cancer, like prostate cancer, is much more common in women and men respectively, neither of those are actually the dominant cause of death because we are able to successfully treat the vast majority of these cases. When we think about staging, and these are some of the things we talk about when patients first come into clinic to make a therapeutic plan, we say first that grade, as we were just talking about, does not equal stage. So grade, as we know, is a pathologic assessment of what the tumor looks like under the microscope from our friends on the pathology team. Stage incorporates multiple factors. Traditionally, it includes the tumor size, the primary tumor size in the breast, the status of the regional lymph nodes, positive or negative, and how many are positive, and the presence or absence of distant metastatic disease. In 2018, these guidelines were updated to include the estrogen, progesterone, and HER2 receptor status, the tumor grade, and something called an oncotype score, which is a risk profile for early stage estrogen-sensitive breast cancer that helps us understand both the prognosis and which patients might need chemotherapy. I just mentioned that hormone receptor positive breast cancer encompasses about 70% of all breast cancers diagnosed. HER2 positive, as we just also heard about, which is a growth pathway, not a hormone, occurs in about 20% of breast cancers. And triple negative breast cancer is defined by what it lacks. So those are tumors that are negative for the estrogen and progesterone receptor and negative for HER2. That occurs in about 10% of breast cancer. Broadly speaking, we'll use terms like early stage disease, which are really focused on stage 1 and stage 2, smaller tumors, often hormone receptor positive, either no lymph nodes involved or very small amount of lymph node involvement. Locally advanced, stage 2 to 3, these are larger primary tumors or tumors with more extensive regional lymph node involvement, or metastatic, stage 4, tumors that have spread to anywhere outside of the breast or regional lymph node. Now, in terms of general principles, how do we approach this? And again, I'm going to focus here on metastatic disease, given the topic of our talk. So for metastatic disease, we typically reserve local therapy for symptom management. That could be surgery or radiation treatment. So we don't typically put patients through big surgeries in the breast or elsewhere in the presence of metastatic disease, but occasionally we will think about, strategic surgical or radiation approaches in the breast or outside of the breast if the patient's having bothersome symptoms. Systemic therapy is really where we come in as the medical oncologist. Systemic therapy refers to drugs that go all over the body to help control the cancer, prevent its growth, and reduce its spread. And for metastatic hormone receptor positive breast cancer, the goal here is really to prioritize estrogen-directed therapies, hormonal therapies, targeted therapies, focusing on long-term disease control while minimizing toxicity. In essence, trying to turn metastatic breast cancer into a chronic, livable disease where patients can stay on these medicines for a long time and have good disease control. And broadly speaking, I often divide these medications into hormonal agents, anti-estrogens, conventional chemotherapy, so these are either IV, oral, or injectable medications that kind of indiscriminately kill rapidly dividing cells, targeted therapies, or some people might call these next generation chemotherapies, which are newer drugs that are specifically designed to block components of the cancer cell that are required for growth, like CDK inhibitors that we'll talk about momentarily. Immunotherapy, drugs that turn the immune system on to fight the cancer, and we see a lot of TV ads for things like Keytruda. These drugs are now very widely used across multiple solid tumor types. And finally, a newer type of drug called an antibody drug conjugate, which is an antibody that's designed to identify tumor cells around the body that's chemically linked to an inactivated chemotherapy, such that when it finds the cancer cell, it can actually drop or deploy the chemotherapy in that region, sort of like a guided missile. And these drugs really were first developed in HER2-positive breast cancer and are now making their way to other types of breast cancer and other cancers in general. Here's a diagram to show you some of the really tremendous progress we've made over the last several decades. So tamoxifen was developed in the late 1970s, and I would argue is really the first, personalized, targeted therapy in all of cancer. And it's a really exceptionally effective and well-tolerated drug. And you know that because 50 years later, we still use it pretty widely in clinic. In the 1990s, we saw the development of the aromatase inhibitors, letrozole, anastrozole, and exemestane, all of which are now also in wide clinical use. These are all pills. In 2002, we saw the first selective estrogen receptor degrader, fulvestrant, which is an injectable medicine. And then starting in 2012 and 2015, we saw the development of the first targeted therapies in breast cancer outside of hormonal therapy. First was everolimus, which targets something called mTOR, which is a part of the machinery that allows cells to survive and grow. And then in 2015, we saw the approval of multiple cyclin-dependent kinase inhibitors. So these CDK inhibitors are oral agents. They're not traditional chemotherapy. And again, they target a specific molecule in the cancer cell that is necessary for the cells to go through division and growth. These pills really revolutionized the way we treat metastatic hormone receptor positive breast cancer, and I'll show you some of that data in a couple of minutes. These drugs are added to the aromatase inhibitors, and when they are added to the aromatase inhibitors, breast cancer patients are able to control the disease for longer and in many cases live longer because of that. And so that really changed the field almost 10 years ago. And now, beginning in 2019 and more so in the last year, we've seen the approval of 3 new oral targeted drugs. First, we had alpelisib, which is targeting again, a piece of the cellular machinery called PI3 kinase. We saw capivasertib approved this year, which targets something just below in the cellular machine, PI3 kinase, something called AKT. Both of these are key cellular growth and division signaling agents. And then we also saw the approval of elacestrant, which is the first estrogen degrader that's oral. So I told you 20 years ago, we had fulvestrant, which is kind of a painful muscular injection. We now have elacestrant, which is an oral pill. I just want to make a couple of comments. The reason I put stars on these last 3 is because these are the first 3 agents in breast cancer that are approved based on a specific genetic alteration in the tumor, meaning we can do the type of sequencing we were just discussing, where we can take a sample from the tumor or a sample from the blood and actually sequence mutations in the tumor DNA. And these are typically not mutations that are passed from parent to child. They're mutations that actually arise in the tumor over time, typically as the tumor develops resistance or progression on prior drugs. And each of these new drugs that have been approved over the last year or two require and are specifically designed for these mutations, right? And they tend to work better in patients that have these particular mutations. I'm harping on this because it's really a revolutionary change in how we treat breast cancer and other cancers in general, where we can really deliver on this promise of personalized medicine. We can profile the tumor and we can change that profile over time. The tumor can actually evolve over time. So we can repeat the profiling as the patient experiences changes in the disease and use that profile in a personalized way to select specific drugs or specific combinations. And this is really the very, very tip of the iceberg. All of the research we're doing in terms of understanding mechanisms of response and resistance to drugs and developing new clinical trials is based upon expanding the arsenal and the understanding of this phenomenon. And because of that, we're really seeing a change in the way providers are thinking about how to treat breast cancer. And as I said, this is the tip of the iceberg. There are many dozens of additional agents, hormonal agents, targeted agents, those antibody drug conjugates, which are in clinical development, phase 1 through phase 3. And we're seeing a real acceleration in the speed with which these drugs are being approved. Just in the past 12 to 24 months, we've had at least 4 to 5 new drugs approved for hormone receptor positive metastatic breast cancer. I'm showing you a couple of them here, but there are others. Here's a sort of simplified overview of some of the drugs that we were just discussing and that we think about as we use these treatments in patients with hormone receptor positive breast cancer. And the question that always comes up for me in clinic is from the patient saying, well, I'm menopausal, how come, you know, I need to block estrogen, right? If I'm in menopause, shouldn't my estrogen level be low? And that's true. Most of the estrogen in any woman's life is produced by the ovaries prior to menopause. That's about 80+% of all estrogen. However, in postmenopausal women where the ovaries are no longer functioning, and in men, there's a small amount of estrogen, about 10 to 20%, that's produced from conversion of steroids that are made in the adrenal gland via something that exists in fat tissue all around the body called aromatase, an enzyme called aromatase. So you get about 80% from the ovaries, but about 10 to 20% from this steroid conversion, which is why even after menopause, there are still some estrogen left around, and that's why these drugs are still beneficial, because we can take that level down even further. And in somebody that has a hormone receptor positive breast cancer, any estrogen that sticks around is really fuel, like gas on the fire. So tamoxifen blocks the interaction between estradiol or estrogen and its receptor, the estrogen receptor. The aromatase inhibitors, letrozole and anastrozole, block that conversion of the steroids into estrogen. But this also explains why they can only be used in women that are in menopause, because if you have a lot of estrogen being produced by the ovaries, blocking this little bit here doesn't matter. And the selective estrogen degraders, elacestrant and fulvestrant, take that receptor and they send it for destruction. They break it down. So no matter how much estrogen is around, it doesn't have its target to function. So these drugs, the pills, tamoxifen and the aromatase inhibitors, as well as the fulvestrant injection and elacestrant, the newer pill, are generally very well tolerated. The pills are given daily. The fulvestrant is once a month injection. There can be menopausal symptoms, you know, occasionally hot flashes, occasionally, you know, mood lability or some hair thinning. The fulvestrant can give you some, like getting a flu vaccine, injection site irritation. The aromatase inhibitors can get some arthritis, arthralgia, and weakening of the bone density over time. There are some rare toxicities. So tamoxifen very rarely can be associated with blood clots, very rarely has been associated with uterine cancer or irritation of the liver. And, you know, when these patients are on these drugs, we see them regularly to assess side effects and routine laboratory studies. They tend to get bone density checks every 2 years. And again, labs at least once or twice a year. More frequently if they're on other drugs, for example, the chemotherapy, CDK inhibitors, et cetera. So here are the CDK inhibitors, palbociclib and ribociclib. They are 3 weeks on, 1 week off, oral pills. The abemaciclib, which is the newer one of the three, is twice daily, given all the time. Again, these are very well tolerated pills. They don't cause hair loss. They don't cause a lot of nausea, vomiting, etc. They can reduce the blood counts and cause fatigue, so we have to watch the labs. The abemaciclib tends to cause some loose stool, diarrhea about 10, 20, 30% of the time. There are, again, rare toxicities. The ribociclib can impact the cardiac rhythm, very, very rare instances of infection or liver or lung injury. So these require more frequent laboratory monitoring, usually once or twice a month, and the ribociclib requires EKG cardiac monitoring. So with that framework in mind, let me just spend a couple of minutes talking about these drugs and sort of how we understand resistance to these drugs. Now, if you go to a talk from any medical oncologist, you tend to see about 30 different slides that look like this. This is how we sort of show the design of clinical trials. I promise not to put too many of these up today because they can all kind of look the same, but I want to just show you a couple of examples of the data that I'm alluding to here. So this is from the Mona Lisa 2 study. This was a very large study with over 600 patients, phase 3, postmenopausal women with hormone receptor positive, HER2 negative, metastatic or advanced breast cancer. They were not allowed to have had prior treatment. So these are the first treatment that these patients have received in the metastatic setting. They were randomized 1-to-1 to receive letrozole alone, which up until 2015 was the standard of care, or letrozole plus ribociclib, one of those CDK4/6 inhibitors. And we're really looking at a couple of things: progression-free survival, which means how long the cancer stays under control in any given patient, and overall survival, meaning how long the patients live independent of how long the cancer is controlled. And here's the data for overall survival. So this was just updated within the last couple of years. And in the yellow line, you see the proportion of patients who are on the letrozole only group, letrozole plus placebo. In the blue line, you see the patients who received the newer drug at that time, ribociclib. And you can see a really significant shift. So there's an improvement of at least a year in overall survival, right? On average, these patients are living at least a year longer by using this drug, which is really a significant difference, and was really exciting when we were able to see that. So as these curves shift to the right, you see more patients are alive, more patients are doing better. And look at the scale here, right? We're talking out now over 5+ years after the diagnosis of metastatic disease, stage 4. And we were just chatting about this previously, and I was alluding to this a little bit earlier, but we have incredibly exciting new technology that's emerging in terms of sequencing tumor DNA. So this is an example of a Guardant test. There are many different companies that do this. What we can do here is actually take a blood sample from a patient with metastatic breast cancer, and the test is able to identify fragments of DNA circulating around in the blood, and it can actually differentiate that DNA as to whether it comes from normal tissue in the body or the cancer tissue in the body. It can then sequence the DNA to tell us which mutations are present or absent. And so here's an example. This is a patient who was diagnosed with metastatic breast cancer, and each of the colors that you see here is a different genetic mutation present in the tumor identified in the blood. So this tells you, first of all, the width of the overall picture is how much abnormal DNA is in the blood. Over time, you can see that total amount of DNA might increase or decrease. And each of these colors is a different mutation. So not only do you learn the total amount of abnormal tumor circulating DNA, you can see how much of it is made up of this mutation versus that mutation, etc. And here, I just want to draw your attention to one mutation in particular. You see this patient, first of all, has a BRCA mutation. But what's also really interesting, excuse me, is this mutation called ESR1. And that's here in the light green. So at the time this patient was diagnosed with metastatic disease, she had the BRCA, but she did not have any mutation in ESR1. ESR1 is the gene that actually encodes the estrogen receptor. This is the gene that encodes the target, right, of estrogen. After the patient was treated on standard hormonal therapy and started to develop resistance to those drugs, we see here with this light green that she's acquired a mutation in the target of the drug, and this is the reason that the resistance has occurred. What's even more important is in 2023, we had the first drug approved specifically for this mutation, a new anti-estrogen drug that I told you a few slides ago called elacestrant, which is particularly active here, and I'll show you that momentarily. So we did a lot of work in the laboratory, our team and other teams, looking at the landscape of resistance, genetic resistance to CDK inhibitors. And we saw that there were mutations in lots of different genes. And we proposed a model a few years ago that looks something like this. For patients with metastatic breast cancer, a one-size-fits-all approach is very unlikely to be successful after the development of resistance to these drugs, because lots of different genes might be at play, different genes in different individual tumors. So each of these genes we identified, and then we went to the lab and showed that by modifying them in breast cancer models, they actually can provoke resistance. more importantly, there are newer drugs either currently available or coming online in phase 1-2 trials that might be particularly effective in these individual patients. And so we hypothesize that for each patient, if you sequence the DNA, you see these mutations and you can reach into your toolbox and pick a specific targeted inhibitor as a kind of intelligent, personalized choice for that individual patient. And these are the sort of studies we're doing and working on right now. Let me just end in the last couple of minutes by showing you a little bit more data about these ESR1 mutations. I just showed you that example of the patient who developed ESR1. So ESR1 is the gene that encodes the estrogen receptor. One of the really important lessons we learned about ESR1 is the value in repeating this genetic sequencing of the tumor over time. If you take newly diagnosed breast cancer, whether that's a primary tumor in the breast or a metastatic tumor elsewhere in the body, from a patient who has never received treatment at all, the frequency of mutation in ESR1 is extremely, extremely low, less than probably 2 to 3 to 4%. But if you sequence those same patients again, months, years later, after they've become resistant to the standard hormone therapies, you see significant enrichment in these ESR1 mutations. It's similar to how bacteria can develop resistance to an antibiotic over time with exposure. And what you start to see is rates of 25, 30, even 40% of patients after they've progressed on, for example, tamoxifen, anastrozole, letrozole, will have mutations in this gene. They tend to cluster in a particular part of the gene here, and they allow the estrogen receptor to be turned on all the time, regardless of whether there's any estrogen around. So it's a way for the tumor to develop kind of a bypass to these first generation or second generation anti-estrogen drugs. This was a really exciting study that was published just a little more than a year ago called the PATA-1 study. And this study, in my mind, really represents the future of cancer care, not just for breast cancer, but across the board. Same patient population, first line metastatic breast cancer, no prior treatment, hormone receptor positive. They get put on, for example, letrozole and the CDK inhibitor palbociclib. The difference here, though, is these patients were getting blood samples done every few weeks, and they were looking for that ESR1 mutation. If the patient had an ESR1 mutation that was detected and then was rising over time, even though the scan didn't show any progression, they were then randomized to stay on their regular drug, which would be the standard of care at that time, versus switch to a better anti-estrogen, in this case, fulvestrant. And the incredible thing here was, again, if you look at these curves, remember I told you when they shift over to the right, the patients are doing better. You can see that in the women who had that rising ESR1, if they shifted early, just based on the blood test, to a better anti-estrogen, they saw an improvement in disease control of about 6 months just in this preliminary study. So this is a really, really important proof of concept. Number one, that we can test the blood serially and in a reliable way detect not only the presence of the mutation, but a change in the frequency of the mutation over time. Number two, we can design a study where we can act on that even before there's any change on a CT scan or a PET scan. And number three, most importantly, that simply by switching from one anti-estrogen to a slightly more powerful anti-estrogen, we can show meaningful clinical benefit. And there are a number of new studies going on right now in the phase 2 and phase 3 setting using even better drugs than the fulvestrant to see if we can intervene earlier, intervene in a personalized way, and shift these curves even farther up, right, improving patient outcome. And then here's the last study I want to show you. This is called the Emerald study and was presented published last year. Postmenopausal women, estrogen receptor positive metastatic. These patients had already had progression. This is not first line. These are women that have had at least 1 or 2 prior lines of therapy. They might have even had chemotherapy. They're running out of standard options in terms of what to use. And here they were, again, sequenced looking for that ESR1 mutation. There were almost 500 patients. They were randomized between one of the other available hormone therapies like fulvestrant or this newer drug, elacestrant. And when you look at the overall population, you can see, again, the curve shifts a little bit, meaning the proportion of patients that have not progressed are doing better, but it was a relatively modest kind of benefit. The improvement here was only from, about 1.9 months up to about 3 months. So, yes, it was statistically present. Yes, the new drug did better if you looked at all patients, intention to treat all patients, but the magnitude of that benefit was, pretty limited. The amazing thing, though, is when you look specifically at the ESR1, notice these are the all patient curves, and there's a little difference, but look at this difference between these curves. These curves shift even farther, right? The benefit here is even more pronounced, again, specifically in the women that have this ESR1. So this is what led the FDA to recently approve this drug, not necessarily in all patients, but specifically in those women that have the ESR1. And what we want to do is use the tools that we were discussing this morning to identify women that have these mutations and to specifically reach for drugs like this that have shown a better track record of success. So here, you saw improvements from less than 2 months to, getting closer to upwards of 6 months. So let me end with just a brief summary and talk a little bit about where we're going, and then I think we'll have a few minutes for questions. So hormone receptor positive breast cancer is by far the most common subtype of breast cancer. In the clinic, we are striving to prioritize and maximize anti-estrogen therapies and targeted therapies and really minimize the use of more toxic chemotherapy. I showed you that CDK4/6 inhibitors have really become the standard of care at the time of diagnosis of metastatic disease. We talked quickly about how the landscape of resistance to these drugs, which we've explored in clinical samples and in the laboratory, is very diverse with a lot of different mutations that can impact it. I showed you how ESR1 mutations, which occur in the target of estrogen, the estrogen receptor, emerge only under selective pressure on drug and predict resistance to some of our traditional agents. And that these novel estrogen blockers, many of them, more than a dozen of them, are currently in advanced clinical trials, phase 3, and are showing favorable safety and efficacy outcomes. And most importantly, we've talked a little bit about how understanding the molecular landscape of resistance to these drugs is really important, and already in real time is helping us to develop and choose new therapeutic strategies in the clinic. So with that, I'll stop. Thanks very much. Hopefully now my screen's off, right?
It is off, thank you. And Dr. Misialek can rejoin us. And I want to thank you both for very informative presentations. If you are interested in submitting a question for the Q&A part of this webinar, please go to the GoToWebinar menu, click on the drop down for questions, and you can type in your question there. In the meantime, Dr. Misialek, I have a question for you. Why do you repeat those ER, PR, and HER2 biopsies on metastatic lesions? Why is that important? Dr. Misialek, you're on mute. Sorry.
Okay, you should be able to hear me now. Okay, thanks. That's a great question, and similar to what Dr. Wander mentioned about tumors evolving over time, either because of selection pressure from therapy, but also biologic evolution of the tumor, tumors can change their profile. In a small percentage of cases, 5%, perhaps even more, a tumor could change from ER positive to negative, vice versa, and even so for HER2. So it's very important to get an accurate representation of the tumor at that point in time. Tumors are fluid, they do change, and we want to be working with the most current information of what that tumor looks like at that time.
Thank you. And Dr. Wander, how are we currently using genetic sequencing for metastatic breast cancer, and how might this continue to evolve in the coming years?
Yeah, thanks. And I think this is the kind of logical progression of what Dr. Misialek was just alluding to, tumors can change their stripes over time, and that's not just true for breast cancer, but I think breast cancer really sets the paradigm for that. And that's true at the level, as we just heard, of the estrogen, progesterone, HER2, but it's also true at the level of the DNA in the tumor. So over time, different mutations might rise and fall as patients are treated with some of the drugs we were just talking about. And so, you know, there's a big change occurring in community practice and in academic practice. Not only really should all hormone receptor positive metastatic breast cancer patients be sequenced with one of these technologies. I typically use blood-based, sequencing. It's less invasive for the patient. It's very reliable. But even more importantly, patients should be sequenced at least 2 or 3 times over the course of their disease, because you start to see these new targets pop up or some of the old targets fall off. And now that we have, our expanded toolbox, you really have to have that information to know where you want to go, right, treatment-wise.
As new information is learned in the future, are you able to go back to the tissue, Dr. Misialek, and perform additional testing if it's requested?
Yes, we can. And by regulations, we're required to keep that tissue in the paraffin block and the slides for at least 10 years, but most institutions keep well over 10, approaching 20 years. So if a clinical trial opens up where we need to have information about the original tumor, we can always go back into the storage, pull that block out. The DNA is still there, it's still preserved, it's still available and can be sequenced. And we will frequently pull cases from the past for exactly that reason, to always have it on hand to be able to compare how things change over time.
Thank you. And for Dr. Wander, what is the best way to approach clinical trial consideration when formulating a treatment plan for metastatic breast cancer?
Yeah, clinical trials are a really important part of the work that we do for all stages of breast cancer, particularly for metastatic disease. And, for example, at MGH, at Newton-Wellesley, at all of our regional partners, we have a variety of clinical trials that can be changing on a day-to-day, week-by-week, month-by-month basis. Some of those trials are for the second-line setting, meaning after progression on standard first-line treatment. Some of them might be for the third or fourth-line setting. So my recommendation is always to have that discussion, with the oncology team, to sort of take a step back and say, okay, at this moment, right, what are the standard therapeutic options? What's the effectiveness of those? What are the toxicity profile of those? And what options might be available, here at this site or regionally? We partner with a lot of our colleagues in the region, Southern New Hampshire, Wentworth Douglas, Cooley Dickinson, right? I have offices in Danvers and Nantucket. Colleagues have offices in Waltham, et cetera. So we might have patients that move from one of those regional sites down because there's a good, exciting clinical trial that might fit the genomic profile of that tumor, and we'll partner, with the oncologist regionally within the network. And it's an ongoing discussion, because if there's not a great clinical trial at this moment, that doesn't mean that 6 months from now, 2 months from now, 12 months from now, there might be a better trial at that point. So, we encourage kind of revisiting that possibility, at each decision point, right? So as long as the patient's on a drug doing well, we wouldn't change anything. But if there's a problem with toxicity or there's a sign of progression, I think a discussion about clinical trials should always be something on the, on the radar, even if it's not the right choice at that particular moment.
Well, thank you both so much. That is all of the time we have for questions today. And I want to thank you both, Dr. Misialek and Dr. Wander, very much for providing very, very valuable information and resources. We appreciate you joining us today. Thank you.
Thank you very much.
Thank you for having us.
So as I mentioned in the introduction, this is the 3rd annual Margo Simon Golden Memorial Webinar. Margo had a vision for the role of Massachusetts Breast Cancer Coalition and what that role could be on a state level, not only for the citizens of Massachusetts, but for the greater good. Through her actions and advocacy, She paved the way to change the world for future generations. With those future generations in mind, I am honored to introduce members of Margo's family who are here with us today. We are joined by Neil Golden, Margo's loving husband, and her stepsons, Andrew and Craig Golden. Neil, Andrew, and Craig, as well as the rest of the Simon Golden family, have been instrumental in supporting MBCC and our mission throughout the years. Craig will present the 3rd annual Margo Simon Golden Distinguished Service Award to Cheryl Osimo, Executive Director of Massachusetts Breast Cancer Coalition. Cheryl worked alongside Margo for decades and considers Margo one of her dearest friends. Craig, welcome.
Thank you. Legacy is at the heart of this award. It honors the legacy of Cheryl Osimo just as it offers the legacy of the award's namesake, our beloved Margo Simon Golden. The Silent Spring Institute, which Cheryl helped create with the MBCC, is named for the groundbreaking book Silent Spring by Rachel Carson. That book too is about legacy. The title of her book was inspired by a letter to the Boston Herald by her friend Olga Owens. In her letter, Ms. Owens wrote about a spring near her Duxbury home. The spring, once filled with singing birds, was rendered silent due to the use of DDT, which decimated the ecosystem. Ms. Carson warned that this silence would be mankind's legacy, a permanent silence from which this world could never recover. Margo would heed this warning, but her legacy is far from silent. Anyone who knew Margo would not describe her voice as loud, but it was and remains a voice that can never be silenced. Her voice is her legacy, and her voice is a call to action. Margo's voice can be heard in the words of today's speakers, proof that her legacy lives on. This award is the embodiment of Margo's legacy. Legacy exists outside the constraints of time, and this is not a Lifetime Achievement Award. It is fitting then that Cheryl is the recipient of this year's award. While the work she has done for the cause of breast cancer is enormous, that work is in no way finished, and Cheryl has no quit in her. I will describe some of her accomplishments now with the knowledge that this list is incomplete. Cheryl will continue to be a fearless advocate for cancer prevention for years to come. Cheryl, like Margo, began her advocacy with MBCC following her own breast cancer diagnosis. She would serve on its board for over a decade. It was during this time that Cheryl first met Margo. We here today are not alone in recognizing Cheryl. Margo immediately recognized a fellow tireless advocate, but more importantly, she recognized a dear friend and compatriot. Margo had a keen ability to see the best in people, and once she found it, she would forever be in your corner. She saw it in my father, and she was always by his side. She saw the best in my brother and I, and would be our strongest advocates. When she saw the best of Cheryl, she led the efforts to have her appointed the executive director of the MBCC. While at the MBCC, Cheryl was one of the founders of the Silent Springs Institute and serves as its Cape Cod coordinator. She has been instrumental in raising public awareness on the Cape of the link between the environment and breast cancer, and would serve on the Cape Cod Hospital's multidisciplinary quality improvement breast cancer team. For her tireless advocacy for the health of the people on the Cape, she would be recognized as a local hero by the Cape Cod Times. Her work, however, spreads beyond the Cape. Cheryl has spoken throughout the state as well as internationally. I could continue to name her accomplishments and recognitions, for they are legion, but I will instead focus on what matters to my family most, the work she did with Margo. Together, they would fundraise and lead educational initiatives to ensure a greater understanding of the environmental causes of breast cancer. Their deep knowledge led to both of them testifying about the issue before the Massachusetts legislature. They worked together for over a decade to improve the health of women throughout the world. They shared an advocacy based on empathy born from their breast cancer diagnoses. They could not allow Rachel Carson's warning to become reality. They would never be silent. Cheryl, I cannot think of a more worthy recipient of this honor, and as you continue to speak for the cause, it will be Margo speaking as well. That is how you honor her. That is how you honor my father, my brother, her daughter-in-law Kate, and her beloved grandchildren Ellis and Saul. That is how you honor the Simon family. It is our privilege for us to be allowed to honor you today, her friend. Thank you.
It's beautiful. Thank you so very much. I received it in the mail last week, and thank you very, very much. Craig, thank you for those kind words. And Margo's entire family, I am humbled to receive this award and will do so in honor and memory of Margo Simon Golden. I am proud to continue the mission that she was so passionate about, a mission to prevent the environmental causes of breast cancer and all ill health. I miss Margo every day, and she should be the one here today to receive an award from all of us for her longtime commitment and dedication. I would like to thank Margo's entire family for how they have always supported Margo's work with MBCC and how they continue to support me and our entire MBCC team in our important mission. Thank you once again, Craig. Thank you, Andrew, for continuing Margo's legacy by serving on the MBCC Board of Directors. And thank you to your wife, Kate, and your beautiful children, Margo and Neil's grandchildren. Thank you, Neil, for your continued support. You have gone above and beyond to support Margo's enduring legacy. I would like to thank our entire MBCC team, President Dr. Barbara Malkus, our entire Board of Directors, volunteers, my family, interns, and supporters far and near in Massachusetts and beyond, for sharing your commitment and love for MBCC's mission of cancer prevention. Thank you, Dr. Misialek and Dr. Wander, for today's informative presentation on metastatic breast cancer, the disease that took Margo from us. Margo, we will continue towards making your dreams come true to make the world a better and a healthier place for our children, grandchildren, and future generations. I almost made it this time. Thank you, everybody. Thank you very, very much.
On behalf of the entire Golden and Simon families, the MBCC Board of Directors, MBCC staff, and supporters, we would like to again thank Dr. Misialek and all attendees for participating in the 3rd annual Margo Simon Golden Memorial Webinar. On behalf of the MBCC Board of Directors, I would also like to thank the Simon Golden families for nominating Cheryl for this award, as I can't think of a more appropriate recipient. I know that Margo would be very proud of her and her entire family, as well as that Cheryl is going to continue this fight in her honor for many years to come. For those interested, the recording of this webinar will be made available later today on the MBCC website at mbcc.org. If you'd like to make a donation to the Margo Simon Golden Fund to help continue the mission of MBCC that she fought so valiantly for, please visit mbcc.org/tribute. Thank you for joining us and have a very good afternoon.